Hi, Andrew. How are you doing? Good to have you here today. And I just want to say it's nice connecting again after 11 years since we first met on the NBC Today show where I was speaking about sex differences in sleep, and then you were a guest along with me and had your viewpoints as a physician and clinician.
Yeah, nice to see you again.
Yeah, great. So today, I thought we'll just talk a little bit about, sort of how you came into sleep medicine and who do you actually see in your practice and a little bit of your research work and your clinical interests. So tell me a bit about your background and how you came into sleep medicine.
Sure. So I majored in biochemistry at Rice University as an undergrad in Houston. And then I did a PhD in neuroscience, also in Houston at Baylor College of Medicine. And while I was there, I became very fascinated with memory in particular and the way the brain forms memories. And so I studied sort of memory at a very molecular level, studying synaptic plasticity. And then after that, I went to medical school and I maintained that interest in memory and started to get more interested in, medical disorders that might impact memory. And so I did a neurology residency. And ultimately, toward the end of the neurology residency, decided that sleep disorders represented a really big class of disorders that could negatively impact memory. And that really interested me. And I wanted to study that more. So I ended up doing a sleep medicine fellowship at NYU and I stayed on as faculty for a bit there. And then I eventually moved to Mount Sinai in 2016, and I've been practicing as a physician scientist ever since then. I see patients once a week, and then do a whole bunch of both basic science and clinical research on the intersection of sleep disorders and memory and disorders of memory really ever since then.
Great. How much generally knowledge do just the public or even the patients who come to you know about this connection between sleep disorders or, sleep versus memory? I mean, is that sort of a common knowledge, or is that sometimes you find yourself educating patients more about that?
Yeah, I mean, I think the awareness is increasing. I mean, I think that people, certainly have a perception that, when their sleep is being disrupted acutely, that, it can have cognitive consequences. That word brain fog, it gets brought up in
Hmm.
my clinic a lot. Right? People have trouble with lots of different aspects of cognition. They have trouble with attention, trouble with working memory, trouble with executive function, these kinds of things, name recall. So people are aware, I think that that is kind of an immediate consequence of disrupted sleep. I think there's maybe less of full awareness that over time, right, that sleep disruption can actually increase risk for not just these sort of short-term disruptions of memory, but really increase risk for neurodegenerative diseases like Alzheimer's. So I think the awareness is starting to increase, but it's something we talk about, especially when people are on the fence, about treatment. Um, we talk and especially if they're largely not very symptomatic,
Mm.
and we have some discussions that, hey, treatment might, benefit you in terms of prevention for things long term.
So you said something about brain fog, which is something we hear a lot from, people living with obstructive sleep apnea. And that's something when they're very clear about that, the way they're cognitively, they're not, they don't feel normal, they're having trouble recalling, and then they definitely use the word brain fog. And we know that OSA, obstructive sleep apnea, has been linked to all-cause dementia, vascular dementia, Alzheimer's disease. Um, Tell me or explain sort of what do we understand the mechanisms of this connection, and also, um, and again, what do we know? Where is the research, and then how much understanding do we have of these connections?
Yeah, sure. So, I think the field has largely taken advantage of the fact that, Alzheimer's disease in particular has a very long preclinical phase. So, years and sometimes even decades before people demonstrate overt cognitive impairment, there's already changes in the brain that are starting to occur, right? And those changes include predominantly things like the accumulation of the protein amyloid, an accumulation of the protein tau, and loss of some, neural synapses already. And these are things that all can occur well before people demonstrate overt, cognitive dysfunction. And so people have evaluated, to what extent various sleep disruptions, including from apnea, you know, uh, accelerate or not, right? The accumulation of things like amyloid and the accumulation of tau and loss of synapses and neurons. And there's, I would say, really good um, correlational as well as longitudinal evidence that's true. And there's some, sort of observational evidence, right, that treating, sleep apnea can maybe change the trajectory of the accumulation of some of these negative proteins and Alzheimer's disease. So that's what's known kind of at a, population level. At a mechanistic level, there's a couple of hypotheses about how, these things are linked. And I don't know that there's like one sort of right answer, and I think these things are not mutually exclusive. So one idea has to do with neural activity during sleep, right? So people have known that sleep is not just a quiescent state, right? The brain is active during sleep, but there are definitely certain regions of the brain that don't fire as heavily during sleep, right? They fire more during wakefulness and they fire less during sleep. And there's evidence that both the production of amyloid and tau are tied to neuronal firing rates. So the more a neuron fires, the more it produces amyloid and tau.
Mhm.
And if you have disrupted sleep, kind of, I guess, really for any reason, but including from apnea, then you're forcing neurons who would ordinarily be pretty quiet during sleep to suddenly ramp up their activity over and
Okay.
over again, multiple times. And the theory is then every time they do that, right, they're making more amyloid, they're making more tau, and that can lead to, more production of these bad proteins. So that's one hypothesis. And then the other has to do with clearance, right? So particularly for amyloid, amyloid is an extracellular protein, and can be cleared out of the brain via various pathways. And in around 2013, there was a really big splash in our field with the publication of a paper in Science that uh, posited that one of the main functions of sleep in general was to aid this clearance of metabolites from the brain, metabolites including things like amyloid. And then if you have disrupted sleep, again, for various reasons, then you're not going to be clearing these metabolites as well, and can lead to accumulation of some of these byproducts, including accumulation of things like amyloid. So there's both a production side of things and then also a clearance side of things when sleep is disrupted. And then I think, sort of one additional mechanism that I think is gaining increasing sort of traction is the role of the immune system. So
Mhm.
um, gathering evidence suggests that a big part of the development of Alzheimer's disease has to do with, sort of immune dysfunction and the immune system's response to amyloid and tau sort of in the brain. And we know that sleep disruption, again, from a variety of causes, can um, at the same time both increase inflammation, but also sort of decrease immune function, right? It's why we think that when you're sleep deprived, you're more likely to get a cold or get sick, these kinds of things. And so there's starting to be more and more investigation into the relationships between, immune system dysregulation coming from things like sleep disruption and the accumulation of some of these negative proteins in also.
So just a little bit upstream, it's really the lack of oxygen, hypoxic conditions that kind of lead to oxidative stress that then kind of trigger some of these things, right? Just to kind of just hope.
I didn't touch on that. That's so everything that I mentioned up to that point, I think is applicable to sleep disruption, sort of broadly speaking, from
Okay.
a variety of causes.
Yeah.
Sleep apnea in particular adds an additional stress, as you highlighted, which is that
Right.
sleep apnea creates both sleep fragmentation and intermittent hypoxia.
Yeah.
And that's problematic for potentially a bunch of reasons. Obviously, neurons need oxygen to do their job, and the more the fire, then the more they need oxygen. And starving them repetitively of oxygen from apneic events, then it creates a mismatch between sort of supply and demand, right? Because especially for wake promoting neurons, right, you're
Mhm.
making them fire more to create the arousal to sleep apnea at a time when the oxygen resources aren't
Right.
there. And so it creates a particular stress on those neurons and makes them more likely to damage and potentially neurodegeneration.
So there is a greater risk for cognitive decline or Alzheimer's with people living with the OSA compared to other sleep disorders. And then sometimes you combine a couple of those sleep disorders, probably the risk even increases further, right? Is that
That's,
somewhat?
I would look at it for sure. Yeah. I mean, I think, and there's been pretty broad evidence, with suggesting that these ties exist between the presence of sleep apnea and the acceleration of.
And we're again talking about people who are not treated for many years, and that's the sort of accelerates the issue. What do we know about people who are actually adherent to their treatment? Do you still see, or again, adherence is not that great when we're talking about CPAP therapy,
Mhm.
so do you think there is more, of course, there's more push in the field to find the right type of treatment or combination therapies, right? So we're making sure that people are getting the treatment. And then, have you done any studies like that looking at CPAP usage or any other treatments versus people without, being, untreated for sleep apnea?
Yeah, absolutely. So, I work with a team of people who published, a series of papers several years ago that took advantage of something called the ADNI cohort, Alzheimer's Disease Neuroimaging Initiative. And so these are people that were followed longitudinally for several years with serial cognitive exams and also serial measures of things like amyloid and tau in the brain. And um, these people were given questionnaires in which they were asked whether they carried a diagnosis of sleep apnea or not. And
Okay.
then secondarily, if they said, yes, I carry a diagnosis of sleep apnea, they're asked sort of a follow-up question, which was, do you use a CPAP machine to treat your sleep apnea on a regular basis? And so what was really interesting about that was that those people that self-reported having a sleep apnea diagnosis that was untreated
Mhm.
had both faster accumulation of amyloid and tau in the brain over time and really strikingly, a much earlier age of onset of converting to mild cognitive impairment, kind of the first stage of what we think of in the development of Alzheimer's disease. So people that self-reported having a diagnosis of sleep apnea that was untreated converted to mild cognitive impairment at around 72 years of age.
Okay.
Whereas those people that said, I have a diagnosis of sleep apnea, but I also use my CPAP machine regularly, they had an average age of conversion of 82 years, right? So 10 years later, right? Because they were self-reporting that they were adherent to their PAP machine. So to me, that was very, very striking. That's one piece of evidence. There's also been work out of University of Michigan that did a big, very big Medicare claims data analysis. They
Mhm.
looked at ICD codes for either the diagnosis of apnea, and then also CPT codes for prescription of a PAP machine. And they were able to cover things like, look at more than one CPT code for supplies as evidence of like adherence
Okay.
to PAP. And and this was like tens of thousands of people. This was a huge study. Um, and they showed that, not only was the diagnosis of sleep apnea associated with a greater likelihood of subsequent diagnosis of Alzheimer's or other forms of dementia, but that um, having adherence to PAP by evidence of these multiple prescriptions for supplies actually decreased the likelihood that you were going to end up with a subsequent diagnosis of Alzheimer's. And so again, that was some circumstantial evidence, but still, I would say
Okay.
nonetheless, sort of interesting and suggesting that treatment, might be actually something that slows the progression. And so, we've needed for a very long time, clinical trials, right? True clinical trials to get at the heart of this. And apologize, I'm going to plug my own study here, but
Please do.
so I'm part of a multi-center team that involves investigators from Mount Sinai, NYU, University of Arizona, University of Pittsburgh, and Sutter Health and UCSF, where we're recruiting people that are between the ages of 55 and 85 who have a new diagnosis of sleep
Mm.
apnea and or have been off treatment for at least 6 months, who are looking to begin or reinitiate treatment. And we're randomizing them to either no treatment for 3 months of time versus treatment for 3 months of time, where interestingly, the treatment is not solely focused on PAP. And I think
Okay.
that's been a big bugaboo in the field for a long time, is that many clinical trials for the treatment of sleep apnea have focused exclusively on PAP.
Hmm.
And in those clinical trials, I think have suffered a little bit because people don't often use PAP optimally when they're randomized to PAP, right? In many clinical trials, average PAP use has been on the order of 3 to 4 hours per night when we know that people are sleeping probably 7 or more hours a night. So you're
Hmm.
getting this like sort of 50% dose effect if you're not, using it for those full 7 hours. Right? So we took this opportunity to essentially offer people their choice of a variety of treatments so they can choose between getting a PAP machine, getting an oral appliance for sleep apnea, or getting a positional belt that keeps them off their,
Hmm.
or some combination of those three. But the
Okay.
goal with the participants is that whatever they choose,
Right.
we will monitor very rapidly for A, how much they use it, and B, whether it actually brings down their apnea hypopnea index effectively. And if either of those things are not true, right, either if they don't use it a lot, or if the thing they choose doesn't effectively make their apnea better, then we switch them to the next thing and the next thing. So over the course of something like 3 months, they get to potentially cycle through all these different, treatment options. And at that point, once we find the thing that we know maximally effectively reduces their apnea severity through a combination of both its efficacy and how much they use it, then the clock starts and we keep them on that therapy for 3 months. And when
Oh, okay.
back at their follow-up, we're looking at measures of memory itself, right? Measures
Hmm.
forms of sleep dependent memory where they encode information before sleep and they're asked to recall that information after sleep. So that's, I think, a really important form of cognition. It's very relevant to sleep. We're also looking at other factors of cognition that, again, are the things that people complain about clinically a lot, right? It's kind of, inability to pay attention to things. So we're having people do a spatial working memory task. We're also having people do an attention shifting task where between trials, they have to shift their attention between what side of the screen something is on versus what direction an arrow is pointing. Um, so a bunch of cognitive testing is the main outcome. And then the other main outcome is these Alzheimer's proteins themselves. So we're collecting blood in everybody. And there's been a huge, I would say, revolution in the ability to measure, amyloid and tau accurately from plasma that didn't exist, say 10 years ago. And so that's really exciting that we're able to very simply, collect blood. And people don't have to do a spinal tap anymore. They don't have to do PET imaging anymore, right? Because PET imaging is a little bit expensive and it's also exposes you to radiation. So we're able to get around these things by having people do blood analysis of these biomarkers and looking at how treatment, impacts change over 3 months. And then those people that were randomized to wait lists, right, for the first 3 months, then have an opportunity to do the same multimodal treatment approach. So at this point now, everybody in the study is on treatment, and then everybody gets followed for an additional 2 years, right? And then we bring people back 2 years later and also again look at these multiple measures of cognition and look at these blood-based biomarkers. So that's a big clinical trial.
That is certainly a big trial. Where are you in this trial at the moment? Are you still recruiting
Yeah, the
people?
trial is actively recruiting. We're about halfway to our target in terms of the subjects across all the sites.
Okay. How many sites are there currently?
5 total sites. 4 of them are recruiting clinically. So Mount Sinai, NYU, Arizona, and Pittsburgh are all recruiting clinically. And then Sutter Health, UCSF is serving as the data coordinating center. So it's different.
All right. Well, we'll look forward to the results. And I guess you still have a little bit of time to complete the trials and then probably analyze all that data, but definitely sounds very exciting. Let me ask a little bit about kind of switching topics. One of the things that we've been focused on is OSA in women, because we know that women present the clinical presentation is different, and kind of it's now picking up in the field that we need to actually focus on sex differences. But we know a lot about sex differences in Alzheimer's disease. This is some little bit of the work that I've done about 10, 15 years ago, where we brought attention to sex differences. Again, just for, our audience, sex differences really means the biological differences between, men and women studying. And have you thought about even looking at sex differences in some of your studies, what do you know when you look at, the sleep disruption as well as, anything related to OSA and how it connects to Alzheimer's disease?
I think it's a great question. As you hit on, Alzheimer's is more prevalent in women.
Hmm.
For a long time, that was thought to be a survival effect, right? So people thought, oh, men are just dying earlier from heart attacks and strokes, and so women live longer to get to be older, so they're more likely to, be more likely to find Alzheimer's disease as a consequence of that. But that's not true, it turns out, right? So even controlling for age,
Yeah.
women have a higher incidence of Alzheimer's as compared to men. Um, there's some thoughts, interestingly, that might be due to, again, what I touched on before, which is these sort of immune differences between men and women. And how apnea plays into that, I think, is a really open question for sure.
Hmm.
You know, I think certainly pre-menopause, there's a protective effect of estrogen and progesterone effect for reasons that I think people don't fully understand very well, but it seems, for whatever reason, it seems to protect against having significant sleep apnea. But around the time of menopause, there's a huge increase in the incidence of sleep apnea in women. And the levels don't go up to my understanding, quite to the levels that are seen in men, but it's really not as disparate as you might think. Right? It's quite close actually in terms of the incidence once you get to be above age 60. Um, and so, look, I think it needs to be studied more. I think, there's a thought that women may have specific phenotypes of sleep apnea, phenotypes that are maybe more arousal heavy than oxygen desaturation heavy, phenotypes that may include a greater preponderance of sleep apnea and REM sleep. So these are things that I think, yeah, need to be looked at and need to be tied to Alzheimer's outcomes.
And again, there's so much education needed for women too. In my experience, I always find women complaining that they have insomnia and don't realize that they perhaps might have sleep apnea or both, and I think there's just a need for so much awareness. But I think you made some great points, even sort of call to action for people to take charge of their health, understand if they have any sleep related issues, and there is actually a consequence for not having their sleep or sleep apnea treated, disruption in their sleep or sleep apnea treated, because there are real life consequences there. Um, Tell us a little bit more about, you touched upon the role of REM, which you said in women, you're finding more of that. But in general, just the role of REM in OSA. And again, what are the clinical gaps, care gaps there? Because again, like you just said, we seem to see more women have the REM associated OSA. But tell us just again, just in lay terms, explain that role and that connection there.
Sure, this is a topic that has long captured my, interest and imagination for a very long time. So all of sleep is broadly divided into rapid eye movement or REM sleep, and then everything else is non-rapid eye movement sleep or non-REM sleep. Um, you spend about a quarter of the night, 25% or so, in REM sleep. And that's something that's thought not to change very much. Unlike some other sleep stages, REM is thought to actually be relatively consistent over time with aging. And it's a stage of sleep that is thought to be, important for formation of new memories, right?
Mhm.
I did some work a while ago where I specifically introduced apnea exclusively in REM sleep through CPAP withdrawal in people that were otherwise adhering users of PAP and had them do a spatial navigation task before and after sleep. And that introduction of apnea exclusively in REM sleep really substantially deteriorated memory for these new spatial locations when people are playing this video game task. Um, and interestingly, REM sleep is a stage where, for reasons that people don't fully understand evolutionarily, you become more or less completely paralyzed, right? So in REM sleep, your diaphragm keeps moving, you keep breathing, and the eye muscles are active to make the rapid eye movements happen. But everything else, all your skeletal muscles, become completely paralyzed. And one of the consequences of that is that you have muscles that surround the upper airway that in non-REM sleep provide some tone and keep the shape of that airway patent. And in REM sleep, that goes away, right? So now that airway in REM sleep becomes very floppy, very easy to collapse, very easy to have a pause in the breathing. So apneas can be either more frequent during REM sleep, or they can be longer duration during REM sleep. And when they're longer duration, that often makes oxygen levels go down further. So it's not universally true, but it can be very, very common that in people that have sleep apnea, apnea gets a lot worse during REM sleep. And there are definitely people that have effectively no apnea during non-REM sleep and only have apnea during REM sleep. It's not completely uncommon. And I and lots of people are interested in whether there's consequences to that. And I think there's some, you know, interesting tidbits that would suggest it may be important. We are doing some work currently looking at people who've had blood collection longitudinally around 3 years apart at baseline and then 3 years later, and looking at sort of what factors, predict change in things like amyloid and tau and blood.
Mhm.
Interestingly, it turns out that the percentage of time you spend in REM sleep seems to be a strong predictor of longitudinal change in amyloid. That's very interesting because, again, this is something that we know that apnea can do, right? Apnea makes REM sleep go down in terms of its percentage of total sleep time. Um, so yeah, like I said, we're super interested in following up on this, understanding more whether REM apnea in particular uh, impairs memory and also changes risk for Alzheimer's. And to your earlier question about, sort of the clinical relevance of this, I do think it is actually very, um, clinically relevant, because one of the things that happens is that people, I think, often don't pay strong attention to the REM specific indices of apnea, right? You get a sleep study and you get this like overall AHI, and maybe
Mhm.
it's like indicating normal breathing, or maybe indicating at worst, mild sleep apnea. But there can be very severe sleep apnea in REM sleep, and people tend to gloss over that, right? It's not paid attention to. And so I think, you know, it creates the situation where somebody can think, oh, this is like not a, you have minimal apnea, this is not a big deal. And maybe it's a bigger deal, right, than the overall index of severity suggests. And another thing that's kind of important is that, a lot of places, including my own institution, Mount Sinai, right, are moving to a lot of home sleep testing
Mhm.
where there's no EEG involved. And so the estimation of REM sleep is either completely absent, or if it's there, it's based on things like pulse variability. So it's not as robust an indicator of how much REM there is or what's really going on in terms of the breathing and REM sleep. And so, it has the opportunity to sort of change clinical
Right.
practice, right? Change how we do the testing or what types of testing we do. I mean, I don't think home testing is going anywhere, but having more robust home testing that can more accurately pick up REM sleep and give you, really believable indices of REM apnea. I think that things that, the field is going to have to discuss more and advocate for more as we get more information.
No, I think you touched upon a great point there. And I think people paying attention to more to the REM sleep. And then again, with the home sleep testing, this is something, again, women, if their home sleep apnea or sleep test comes back negative, is to still follow up for an in-lab test just to see where, it is. And this is something we have in our educational materials that we've created to make that a point, saying that, especially if it's the REM sleep that's causing, or disruption in the REM sleep that's causing OSA, or whatever the connection there, between the REM and OSA, is important for them to follow up and get that in lab testing done. And I think, yeah, I think there just needs to be more awareness of the role. Just again, out of curiosity, with this whole memory consolidation, or problems with memory processing, are the dreams or anything else impacted in these patients? Have you heard anecdotally people complaining about their dreams, or not being able to remember if they've had, any dreams at night? Have you heard anything like that?
Yeah, I mean, certainly on occasion clinically, people will say that they're actually, dreaming of, right, drowning, or that they're underwater and they're trying to get to the surface, and it may be the body's right interpretation of what's happening
Right.
physiologically, right? The body is physiologically experiencing an apnea, and that somehow gets incorporated into dream content, that, yeah, you're somehow like suffocating or drowning or something. So I've certainly heard, clinical stories like that. What apnea does to, you know, dreaming is a sort of really interesting and open question. You could hypothesize that things might go either way, right? That like
Like,
you either disrupt REM so much that dream recall is going to be bad,
mhm.
or that because you're introducing these like multiple arousals into REM sleep by virtue of having apnea, that maybe that actually is going to foster dream recall because of these multiple transitions to wakefulness briefly. Um, years ago when we did that study, we did ask people in a morning questionnaire, whether they, sort of dreamt about or re-experienced in any way this sort of 3D maze environment that we'd given them pre-sleep.
Mhm.
And because we did this within people who were experiencing two different conditions, right? A normal night versus a REM apnea night. We were wondering whether there may be changes in these sort of dream recall scores. But what was interesting was, this is, again, it's a relatively small sample size, but most people did not change their dream recall.
Oh,
People were either, yes, I remember, and yes, I remember, or no, I didn't, no, I didn't. Very few people changed. So it seemed like, ability to recall dreams, at least from that study, was something that was person specific and not condition specific.
yeah, no, that's interesting because again, some of the things I've heard are, just anecdotal. So what actions can someone take with OSA to reduce their risk of dementia and also improve their overall brain health? I mean, what kind of messaging that ASAP can also give to, people with OSA?
Yeah, look, I mean, I think it starts with just, awareness and paying attention to what, your body's telling you, right? I mean, I think, uh, right, snoring, number one, I mean, should potentially be evaluated, right? I mean, particularly if people also have complaints that they feel like, sleep is not good quality, they're waking up feeling unrefreshed. If they have any of this daytime dysfunction in any sort of way, whether it's daytime sleepiness, daytime, lapses in attention, daytime brain fog. I mean, those would all be, to me, strong indicators to please go see your doctor, please go talk about it, please be tested. Um, and then once you're tested, I think the other message is that, we're really, the field is growing so much in terms of treatment options. I mean, PAP definitely is the gold standard. I mean, it's very effective, but we're just, there's so much more and more that's coming out these days. Oral appliances, positional therapy, different upper airway surgeries, Inspire, and on the horizon, we're going to have probably multiple new medications for sleep apnea. So I think it's a really exciting time for the field. And I think, tirzepatide, right, with the weight loss. I mean, there's so much now that I think it's really should hopefully encourage people, right, to know that there's going to be lots of options, right, that you're not going to necessarily be forced into this one treatment option paradigm, and that there's really a lot out there. So I think that's to me the message.
That's wonderful. Well, thank you so much, Andrew, for taking time today to speak with me. And this was a great, great conversation. And look forward to working with you more.
Thank you, Monica.
Thank you.